Let's get the show on the road. So I'm Anna Kasakis. I'm a psychiatrist, and I am the co-chair for Psychiatrists for Community Empowerment, or our community psychiatry group through the New York County Psychiatric Society. I am co-hosting this with Dr. Greenspan, from the president of the Nassau Suffolk District Branch. And our special contributor, who sort of spans all worlds, Dr. Angela Liu, who is a first-year resident at Zucker Hillside and is a district branch member over at Nassau Suffolk, but involved across the board. So before I get into introductions of our panelists, wanted to thank both district branches, both New York County Psychiatric Society and Nassau Suffolk, for allowing us to put this on. Selfishly, I have been sort of struggling, I think, with the mayor's initiatives, trying to wrap my head around what we should be thinking about this as psychiatrists, as advocates for our patients, for as good human beings, and really wanted to be able to get folks who know what they're talking about on this topic at the same table, to be able to straighten out some of the confusion in my own brain on this. And so voila, here we are. And I really appreciate you all joining us here to be able to talk through some of these issues and maybe come up with a common place for us as psychiatrists to think about this, and then be able to advocate in the community. Because I think part of this is we all don't really know where we should stand, where this all falls in reality versus in theory. And perhaps we might be able to have a call to action by the end, or perhaps it just might be a stimulating conversation. So either way, I truly appreciate all of you being here. I wanted to introduce our panelists. They are very busy people, so I did not get bios for a good many of them. The folks who were not able to join us, Jeffrey Newman and Jason Connor, both Angela and I have worked with through Backpacks for the Street, and they started a nonprofit that really does street outreach and more of like a peer initiative. And so it would have been interesting to hear their perspective from having formerly been also undomiciled, but now being such strong advocates in that area. But all the best to Jason, who is recovering from a procedure. We do have two lawyers with us from the mental health service line. Mental hygiene legal service, sorry. We have Lisa Caliguri Boranian. Lisa, did I butcher that?
Nice to be here. Thank you.
Okay, good. Now Lisa is has been practicing law since 1988. And has dabbled in all sorts of things, including private practice, and but has been with the mental hygiene legal service since 2005, and is going to assume the position of principal attorney on April 27th. So I love when strong women rise up through the ranks and represent so well. Lisa, congrats.
Thank you. I appreciate
that you're able to join us with all of your experience. And also from the mental hygiene legal service is Jillian Becker, who last minute was able to step in and help us out. Now, Jillian's also been working in this arena for 22 years, representing everyone who can't represent themselves, has worked both in private and public acute care hospitals, as well as in the state hospital, and really has seen the housing crisis in NYC and the homeless issue from her vantage point. So very interested to hear from both of you on all of this, and maybe translate some of the legal mumbo jumbo that comes along with these initiatives so that we can better understand it. We also have Dr. Matt Goldman joining us from California. He is the medical director of the Comprehensive Crisis Services at San Francisco Department of Public Health, and was a former resident at Columbia, where I had the privilege of crossing paths with him. Matt, anything I missed in terms of introduction?
That's great. We can leave it at that. I'll chime in with thoughts that might be relevant. Thank you.
Perfect. Thank you. Dr. Becky Capasso is a unit chief at Bellevue Hospital and the former medical director at Project Renewal, which serves the homeless population. And Becky, you are going to be president of New York County Psychiatric Society, or did I make that up in my head?
No, you made that completely up in your head.
Okay, well, it will happen. I have just manifested it.
Becky, do you want to be?
Well, there you go. There you
Stop
go. Well, we'll have to see
Mike.
it in the universe now.
It's there. And then we also have Dr. Ellen Rodriguez Penny, who is a psychiatrist at Janian Medical Care, doing street outreach with this population. And he grew up in Puerto Rico and completed psychiatry residency at SUNY Downstate, and finished a public psychiatry fellowship at Columbia. So his interests include drug policy, harm reduction, and psychedelic assisted psychotherapy. So that is our very impressive panel.
NYCPS president. He's going to be the.
He is going to be president. See, I'm like all confused today. Dr. Rodriguez Penny will be the next president. Dr. Capasso will follow soon after. How's that? All right, very good. So to kick this off, I was hoping that you all could help us understand a little bit about what exactly is meant legally with the current mayoral initiative on homelessness. So as far as I understand, previously we had a very strict rule about the criteria for involuntary hospitalization, meaning, right, do harm to self, harm to somebody else, and ability to care for self. And with the mayor's initiative, someone who is street homeless could qualify for this if they have an untreated psychiatric illness. And so I'm curious how this is translated legally, like what the actual law and the initiative means legally, and for those in the clinical space, perhaps how that has spelled out in real world. And for Dr. Goldman, after that, how you think that would work in San Francisco, and if anything would apply. So perhaps we could start with our JDs.
Okay, so I'm going to jump in, and then I'm going to let Jillian jump in.
Thank you.
So my understanding is that the sections of the mental hygiene law that are being used in this initiative have been part of the mental hygiene law since inception for years. Section 941 and Section 958. 941 authorizes a peace officer or a police officer to pick someone up for the purpose of a psychiatric evaluation. My feeling, and Jillian will join with me on this, but my feeling is that it's going to be an evaluation similar to a 927, which you in the hospital world may know as a 2PC. So an evaluation to see if they are a danger to themselves and others. The second section is 958, which authorizes a designated clinician. So a physician or someone in the mobile crisis unit, or approved by the State Commissioner of Mental Health, a licensed psychologist, a registered nurse, licensed clinical social worker, or a licensed master social worker under the supervision of a physician, psychologist, or licensed clinical social worker. So what they have done is they've dug deep, and they found that these statutes existed. In my mind, this is what happened. And that they decided that the homeless crisis in New York was such that, how can we do something about this? And this is what he based the initiative on. Jillian, you want to jump in?
I would just say that it doesn't change the law at all.
No.
Right? There's still a standard to admit someone into the hospital. Where I work,
Good. Have a good night. All right.
where I work generally, people are being admitted more on 939s or a 940 status to a CPAP,
Mhm.
and then converted to a 2PC or a 927. In some private hospitals, people are sent directly on a 2PC, but the law is still the law, and this doesn't change that. I'm agreeing, though, that this is just an initiative of bringing people into a hospital setting.
Jillian, have you seen many admissions under these? Because I don't believe we have in Queens. So I work exclusively in Queens. And I would tell you that Jillian probably sees more of the homeless brought into her. She's at Harlem Hospital, but I was in Manhattan on Sunday, and I got an eyeful when I was there. In fact, I moved someone from the side of, he was in the middle of the street. He was half asleep or whatever he was. And I actually told him, hey, buddy, let's move over to the sidewalk because you're going to get hurt. So I think that you see more of it in Manhattan and the Bronx.
So
than
I
I
work
do
in the first
Queens.
department, which is Manhattan and Bronx. Dr. Capasso probably has a lot to say about Bellevue too. We used to work together down there. I have seen an uptick, right, of people being brought to the hospital. In my opinion, there's two different issues here, right? There's the homeless issue, where unless somebody gives a large amount of funding to housing, that's always going to be an issue. And the next is the mental illness population. So with that, unless you invest in outpatient services and unless you invest in community-based programs, and unless there's something more than just this initiative, nothing's going to change. Right? People can be admitted to the hospital on whatever standard they meet, whether it's the higher emergency standard of a 939 or a 2PC. But once that person is stable in an acute care setting, it's time to be discharged. So although
They're not keeping them long, I agree with you. They're not keeping them.
Although I see an uptick in my admissions, it doesn't mean that the length of stay, for some people it is growing, right? But for others, it's not. And it's just a question of, this is a temporary thing where someone is taken off the street because they're homeless and they're brought to a hospital for treatment. Whether they get that treatment or not depends on how severely ill they are. And then they're returned back to the community. So I think that this is really great in media, but it's not changing anything, nor is it helping any of my clients or the patients.
And remember, as Jillian said, the law doesn't change. If once we see those individuals, because we cover these hospitals, Dr. Liu, you know, we cover Zucker Hillside, we cover these hospitals. If the individuals want to make an application to be discharged, they have a right to make an application to be discharged, and a hearing will be held. We have court every week in Queens. I know that you do. We have Tuesday court for certain hospitals, Thursday court for other hospitals, and they have a right to be heard. Whether we win or not is another story, but they have a right to put in an application to be discharged.
I think, Lisa, what you stated was super appropriate, that they found these sections of the statute.
They dug deep.
Yeah, and they came, but the law has not changed. And that's the key thing here. Nothing has changed in terms of, you know, there's a standard of clear and convincing evidence. You have to prove that someone is a danger to themselves or others. And I think that being homeless, depending on what status you're on, could be looked at as a danger, but I'm not sure that's the end all be all.
I think that, you know, there are ways to fight the admission. saying that I wasn't doing anything. A lot of police officers now have body cam. So as part of MHLS's defense, we can ask to see the video. Let's see what they were doing. If they weren't doing anything and you just pretty much plucked them up off the street and put them into an ambulance, that is not a strong admission. But the law, as I understand it, is solid. It's there.
And I found that just the opposite in Harlem. They will take somebody who was doing nothing off the train and bring them in. And they may be mentally ill, they may have other medical conditions, and now all of a sudden they want to treat them. And they might meet the definition of the legal standard to keep them for treatment, where in the past, if that person was just pleasantly sitting and not minding their own business, they would have never been brought in and forced into treatment at that time. And that's the difference in Manhattan, at least, that we're seeing, is that people that really, we never really had contact. They weren't our regular people that cycled through that were being picked up for a dangerous act or a fight, or someone called EMS or NYPD on them, is now being brought into the hospital and forced treatment at some level.
I'm curious how this then plays out for Dr. Capasso on the inpatient side and Dr. Rodriguez-Penny from the outpatient side, right? With this patient population and what their perception might be of this, and also how it's one thing to get someone like this in the door, but are all of these treatment over objection patients, or are they new converts to mental health and entering the system happily? Just curious how this plays out.
So I'm associate director of inpatient at Bellevue. We have definitely seen an uptick of folks coming in who are chronically street homeless. They're well known to us. They do have a mental illness, but their length of stay, in my opinion, is increasing. I don't have hard facts to back that up, but there is a big push there's a new state hospital unit called the THU. So right now, I can give you an example. There's one guy on my unit. We all know him very well. He would come in, get his shot, and then leave. He has an IMT team. He is chronically disorganized. He is certainly schizophrenic. He wasn't doing anything acutely dangerous, but people had called because he was in the same spot. And after a certain number of calls, they brought him in. And now he's been sitting on my unit waiting for this special state hospital bed to get fast tracked to housing, which is wonderful. He doesn't want any of it. He says, I took my shot. I want to go. I want to leave. I don't want to be here. So I think that we are going to see a slight uptick in that. I think that as we're all talking about this too, the elephant in the room is, I think I have major concerns about NYPD choosing who gets picked up off the street. I think there's going to be internal inherent biases, racial biases against people who have mental illness. They seem strange. And we've had a lot of really tragic losses of people who've died in an interaction with the police because the police have been told to go deal with this person who's not reacting in the way that, or complying in the way that they want to. So I think that's a significant risk that should not be forgotten. And then, yes, this is involuntary treatment. None of these folks are voluntary. None of them decide, I do want to come into the hospital this time and get care. They may agree to part of the treatment. They don't want to go to the housing unit and get housing. Those resources are available. Shelter is available. Most of these folks have been through the shelter system, had all of their stuff stolen, can't follow the curfew, can't follow the rules, don't want to go through that system. Unless we have truly a housing first model and we can get people into some kind of safe and stable housing, and unless they have some kind of very strong relationship with that outpatient team, that IMT team or whatever, this problem, I completely agree with Ms. Becker, who's taken me down many times in court. It is still following the same law, but we are restraining more people, taking their rights away and putting them in as always, the most restrictive environment, an inpatient hospitalization where they can't get fresh air, they can't go outside, they can't go live their life, which is all like the gentleman that I'm using as my little example, that's all he wants to do.
Yeah, so I would also add to that. So I work with people who are currently or formerly homeless. I work in different settings. I'm actually on an IMT team and also do outreach in Queens. And one of the challenges we've had just generally is that some of our vulnerable participants who cycle in and out of the emergency room because they go in, but they're not acute enough to be admitted, yet at the same time, like they would really benefit from psychiatric treatment. We've had those situations where it could be challenging. Most recently, so some of our participants have gone to the THU. So THU stands for Transition to Housing Units. They've opened 25 beds recently at the Manhattan Psychiatric Center. And those beds are meant for people who are homeless with a serious mental illness. And it gives the length of stay is a bit longer than your typical inpatient stay. And the idea is to, once they get discharged, they either have housing already set up or at least have their housing package set up. And so we have at least 2 people there. And then someone who's in the inpatient unit who's actually like wants to go to THU because he's aware like that does offer more resources in terms of housing. So I've had that situation where someone is actually like, you know, I want to get out of this hospital and go to this other place where it seems there's a bit more of a path forward. But overall, like I do agree having resources in more community settings and services. So like ACT team, IMT teams, things like that work, supportive housing models work. And I've worked like in permanent supportive housing as well. And so those are resources that also need investment and resources. And like overall, I think people have been putting a lot of like resources and emphasis in it. It's just that the demand and the amount of time it takes to actually build up, especially like if you're adding like a new building for permanent supportive housing, that takes like 5 years or who knows how long. Like it'll be a while before those units come online and you're addressing the problem that's happening now 5 years from now. So that's one of the challenges here.
So I'm curious if this is the right approach then. I mean, I'm hearing, right, that there are potentially some folks that might be benefiting from this, but is this even the right way to go? And sometimes stepping away from that and seeing from a perspective, perhaps from another coast that has battled this for quite some time might be helpful. So Dr. Goldman, curious what you think looking over at your old stomping ground, tackling this while this is sort of your bread and butter world, I think, out there.
Totally. Thank you, Dr. Kistakis. That was a 10 out of 10 segue. It's really interesting to hear you guys talking about this. I followed the Mayor Adams story pretty closely because it was getting headlines, but also I think, you know, as New York goes, we think as California goes, so goes the nation. But sometimes as New York goes, so goes the nation. And this is making a lot of headlines around these really sticky issues around involuntary commitment and how's it supposed to be used. Read loud and clear, the law didn't change, but it seemed like there was sort of like a new pressure to stretch, right? And laws are not black and white, and how they're applied, it can be interpreted broadly. And there have definitely been efforts at something similar here in California. So just really quickly, like a couple important context points that are different. California does not have a right to shelter, whereas New York does. So we have much more street homelessness, people who are living on streets. That, of course, is partially a reflection of our weather is warmer and not so dangerous during the winter. So there's a little bit of that, but we also just have vastly less shelter capacity compared to New York. We also have way less inpatient capacity. Like I sometimes miss the days being a trainee in New York City where there was so much inpatient bed availability when we had somebody who truly was in an acute psychiatric episode and needed that support. Here we are discharging people all the time who I would have admitted in New York in a heartbeat. So it is just a different landscape here. It's really quite challenging, and the standards are much higher for inpatient admission, in part because of that just capacity limitation. And so with that said, then like, so what do we do about it? So there have been a couple state initiatives that have gotten a lot of press ourselves. Many of you likely saw Care Courts is a major initiative of Gavin Newsom, where it's, many of you I'm sure are familiar with AOT, assisted outpatient treatment, which basically mandates the patient into treatment. What Care Court basically does is it mandates the county to provide treatment. So it's not a mandate that's requiring the individual patient to receive care, but rather saying, hey, county, these people in your county are your responsibility and you got to do something about it. And so the judge is basically ordering the county to provide services as defined under a care plan, which includes mental health services, substance services, housing, and others. There are many issues related to this. I'm speaking here as me, not as a representative of the Department of Public Health, I should say. There are some challenges here. Resources are finite, and Care Court does not come with it an increase in resources commensurate with the likely increase in demand for those services that are going to come through these mandates. So that's just sort of an obvious major issue. There are also issues about patient population who's coming through the Care Court process, which there are some particulars about the law that I don't need to get into detail about. But I think some of the main issue is, and this was sort of referenced earlier, if the fundamental issue that's trying to be addressed is homelessness as like a primary thing, homelessness is a housing problem. The solution to homelessness is housing. Homelessness is not going to be solved with mental health services. Now, I will say, I think that sometimes we fall into zero-sum discussions around like resource allocation. Should, we should not be doing more mental health services. We should just be focusing on spending those dollars on housing because ultimately that's what's needed, and housing first all the way. Housing first is our best evidence-based intervention for people experiencing homelessness who are in a mental health crisis or have any kind of serious mental illness that needs care, permanent supportive housing, all the interventions that Alan referred to. And there are people who are living on the streets who need help, right? And so that's like, there is a reason for having street psychiatry type interventions. But there needs to be a balance there, and that's not always easy in a resource constrained environment. But I do think that there's value in exploring both, like, how do we really address this on the housing side, and what are the mental health type services that are actually going to be useful as opposed to potentially detrimental, like cycling people through involuntary treatment in a way that can be quite traumatic and undermining of treatment alliances for future care. The last thing that I'll say is when states mandate localities to do things, they have to understand the implications of those mandates. So in this case, I guess it's the mayor mandating localities to do things, although New York City is basically a state in its population size. And so in California, there's currently a lot of energy around the debate around criteria for involuntary holds, where right now our definition of grave disability is no access to food, clothing, and shelter, which I believe is the same in New York State. I don't remember actually if medical is a criterion for grave disability, but that's currently being debated in California is should inability due to a mental illness, inability to care for one's medical needs, should that be part of the grave disability definition? And there's a lot of good reasons for it. I my heart breaks when I'm seeing somebody in the psych emergency room who has some serious medical condition, whose life is truly in jeopardy. They might, lose life or limb literally as a result of not caring for their medical needs as a result of a mental illness. And like, if we don't have the medical resources to actually provide care to people who get placed on hold for grave disability because of that new definition that includes medical, then are we even actually able to help those folks, even if we do place them on a legal hold that now covers that? So that idea, like the reason that I say that, and this is the final point that I'll make in this little ramble, is kind of circling back to Alan, what you were saying earlier, like there are things that work. There are programs that work. Permanent supportive housing works. IMT, ACT, like all the different evidence-based programs, these work. But if you're going to mandate certain activities, you have to provide the actual services that are then going to help the folks that you're mandating them into or involuntarily committing them to. And so like, I think that just as a guiding principle, like ultimately involuntary holds are a tool, they're a means to an end. And if the end is not available, then there is real risk of doing more harm than good in terms of exposing somebody to involuntary transport, to IM, seclusion restraints. You guys have all seen this, you know the deal. And so to really take that into account, and when ourselves are in a position of making those involuntary treatment decisions, like I think that there is space for interpretation both ways. And shouldn't we be responsible for flexing in a way that's actually taking the patient's best interest into mind, as opposed to sort of the mayor saying, hey, we don't want to have to deal with these people on our streets anymore.
Dr. Goldman, I'm just going to jump in for 1 second because I agree with you. And you said something very interesting at the beginning about the weather in California. And I think if I'm right, this whole thing came around in November of last year when the weather was getting cold. We had several cold spells in New York. And I think that was when they started digging for something to get the homeless, because people had been complaining about the increase in homelessness following the pandemic, during the pandemic, following the pandemic. And then it got very cold a couple of times. And I think that's right around the time that this happened. But it's interesting what you said about the weather. You do have better weather than we do.
Yeah, no, that's really interesting. And yeah, I mean, weather's part of politics. Yeah.
It shows you that it's about the homelessness and not about really anything else.
Right. I am curious about the grave disability, the medical comorbidity, and whether that applies also in New York. As an outpatient a psychiatrist, I actually have no idea. Do you all know?
Yes, it does. So if I have a client who has some serious medical concern that they can't take care of, that is an argument I can use as to why they need to be inpatient, to get that scan, to get that surgery, to get that service before they'll be able to go back on to the street, the shelter, wherever they're headed.
So legally, there's a little bit of a difference there, right? So if Dr. Capasso is going to argue that this person needs to stay for medical care, we don't have the best interest standard. We represent what our client wants. So if my client says to me, I want to leave the hospital, I'm not thinking, but wait a minute, what about your toes that are going to be amputated? Personally, we ask our clients and we try to push towards if there's something that we can negotiate that would get them the help they need prior to going to court, and then maybe stipulating to something where they can leave at a certain time, that would be great. However, the way the law is written is that there has to be a nexus between the dangerousness and the mental illness. So if someone is coming into the hospital that's in an acute psychotic phase, that could be determined very easily. However, if someone's been on an inpatient unit for X amount of time and acutely their psychosis has been helped through treatment, then it's really a different argument from our perspective than Dr. Capasso's about whether that person really needs to stay for this medical treatment. I have won cases where I have cried as people have left the hospital thinking, oh my
Right?
gosh, what did I just do?
We
to
don't
this
have an easy
person?
job.
But, that's what it is. So in New York, it's really not, you just can't keep someone for a medical procedure. We do have different laws that if someone,
Guardianship. This is when guardianship would kick in, right?
correct, or even a
When
mulch,
hospitals
or
apply for
even,
guardianship, say that the person can't take care of themselves, have functional limitations. I do a lot of our guardianship work in Queens, and a lot of our new guardianship applications are brought by the Department of Social Services. Not either because the person we do have homeless cases. We have hospitals bringing cases for guardianships because they believe that this person can't make the right decisions. There's a lot of reasons that guardianships are brought, but
Harlem Hospital a few years ago brought an application to give a woman a C-section and put an IUD in. And obviously that was not granted, and the judge would not even hear about the IUD, but the C-section was like a real thing. And they did it under like the FHCA, or the Family Medical Care Act, which we see a lot of hospitals do. And I was like, wait a minute, there's another party to this. Is there a boyfriend? Did we look for the boyfriend? Did we look for the baby's father? And finally, the judge was like, we're coming back at midnight. He works till midnight. We'll have him come in. We didn't have to come back. He ended up consenting to the C-section, and she went along with it. But there are other, avenues legally that they can take for medical procedures over one's objection. But mental hygiene court and what we do is not that.
So curious, from all of your different vantage points, if you were, I very quickly elevate all of you to the new presidents of whatever you want to be presidents of, because I am in awe of your work. But if you are stepping into the role of Mayor Adams, right? We lose him. You're stepping in. You are shaping this, and you have full control. What would you do to solve the issue of our homeless population, the mental health issues there? How would you prioritize that? I'm curious. No one wants to be mayor.
I could say, I stated this when I first started. If we are trying to solve a housing issue, there needs to be more housing, right? I don't remember who said it best, but you can't wait 5 years to build a facility to house people when we're trying to help them today, right? There has to be available housing for someone. From my perspective, and as a lawyer from Mental Hygiene Legal Service, outpatient services need to be readily available to people. If you're at a point where you're medicated and you're stable and you're leaving, and you do not have that connection with an outpatient team, or you do not have somebody that you feel that you can rely on, and you do not have services available to you, then we're not helping anybody. We're just going to end up in the same. I have a client right now that I know extremely well. And why did she come in? She's living at TLR in Manhattan, and they didn't give her medication. They just did not, and they admitted that we messed up, we didn't give her, so she decompensated and ends up back in. That to me, she has housing, it's TLR, which is a transitional living residence, but if we're not going to staff them with adequate services, then we can't expect her to do well.
Right. I actually like your point, because that speaks also to a workforce issue when thinking about quality over quantity. And we're thinking about like expanding services and programs when the existing ones need help. So that's another like point that adversely affects the people we serve. Like if it's not staffed right, or people are burned out, then you can't provide good service.
I wanted to say the exact same thing at the same time. So the push from the mayor is to open more inpatient beds. So there's only 2 MDs on my unit full time. We were at a census of 24. Now we are at a census of 30. So that is covering 15 patients with no additional social workers to do the 2010E, to connect them to housing. And the number one thing that I hear, and the push is, again, I see there's money for housing, which will take years. There's money for more CPAPs. There's money, there's money to open state beds. I'm not seeing there's money to pay people working in the public health system or in community psychiatry a wage commensurate with other people. There's not incentives to keep people in that work. They'll burn out and leave. And I think all of that could be done, and we don't need to be taking people off the street and getting them evaluations in CPAP right now. We need to be building all of this. It almost feels to me at times like deinstitutionalization all over again. We're going to shut down hospitals. This is the opposite. We're reinstitutionalizing people, right? So deinstitutionalization was we're going to shut down the state hospitals and everyone will get this great outpatient care. And then that wasn't really built. And so we had a lot of trouble with that. And now, because instead of, again, doing the services, we are reinstitutionalizing people. We're expanding inpatient and state hospital beds. And this is my job and I love it, but that is not what we need. And we don't have more services. I think my number one pet peeve in my job is the number one thing that every team asks for. I've had someone in supportive housing with an IMT team on AOT, and they'll say, but they need a higher level of care. And I say, there is no higher level of care. There is nothing. So, and then they'll say, but they can't return, they can't handle it, they need a higher level of care. And I'm like, what does that mean? And I would love to know, if I were the mayor, what does that mean? What is a higher level of care than that? And I will happily try and set it up for them, but there's nothing.
Yeah. Another thing that I would add is there's something about like the ethos of how we approach this work, and thinking about how to meet people where they're at in a low threshold way, like in a low threshold meaning in a way that's like accessible and on their terms. I will say, like, my experience comparing New York to California is that New York is much more comfortable with a hefty dose of paternalism than California tends to be. New York State and all government not shy about telling people what to do and putting them where they should be in the state's opinion. California, much more person-centered, and the way that that can be a slippery slope because there's risk of like rotting with your rights on, we won't touch anything, civil liberties until infinity, and then people are dying on the street. So there's a risk there. But there is something, I've seen this play out in a couple of ways, where like really person-centered care, like really trauma-informed care, all of these buzzwords that we hear thrown around all the time, like what it actually means is basically like meeting people where they're at and helping like facilitate an opportunity for connection and trust building with a system that has traumatized people so repeatedly that they don't want to talk to you and interact with you at all. So it's like people who are experiencing homelessness chronically, people who are potentially diagnosed with a serious mental illness, but more often than not have a co-occurring substance use disorder, right? Where, I mean, there's so much overlap here. Like, if it worked to compel somebody into substance use treatment, like I might be open to that if it helped them, but it doesn't work. So like, we shouldn't pretend that just making people enter into substance use treatment is going to help them. It doesn't work. Compelling people into mental health treatment, there's not actually a super strong evidence base for that either. AOT has been studied a bit, so for that population maybe, but like involuntary holds and treatment as an intervention, not a robust evidence base for that even. And so like, what are we actually doing here, like to help people? Like often it's like, and Alan, this is where like you're doing God's work. I feel like this, like the outreach and, meeting people where they're at type work, that is like, in my experience, that's the model of create settings where there are no barriers, where people can primarily focus on getting their Maslow's hierarchy of need, met, water, food, clothing, shelter, like ideally, Like, and by building relationships over time, you can build trust. They can start to actually think that you're not just going to like send them through another involuntary hold cycle, and that you're actually going to be able to help provide them some of what they need, not what the system wants them to do or wants them to need. And only by opening up that little lens of like trust and engagement is there an opportunity for hope and readiness for change and potential motivation for engaging in services. Like, I think that is like the foundational premise that I think is so important for actually, making any headway. Because by just forcing people to do stuff, you're just shifting people around and you're not addressing the issue. And that does become a true human rights violation, I think. And so like, but it's very hard to operationalize that. And so like creating services and systems that actually facilitate this kind of trust building care, it's expensive. There are burnout issues, there are safety issues that are real, and we shouldn't pretend that there aren't. The integration of mental health and substance use is like not a strong point in New York State. Like there's a lot of structural barriers there, but I think like any step in that direction I see as like a step in the right direction in order to actually eventually make change. And I will totally selflessly plug in, putting in the chat here, an article that's a review article, which I actually wrote with a bunch of New York people about low barrier psychiatric services. So this is a psychiatrist audience. This might be of interest to you guys in terms of like best practices for providing in low threshold settings and sort of considerations and monitoring and like, how do you do this safely, but with a big focus on the like, engaging people in sort of self-management support and collaborative decision-making type clinical settings.
Beautifully said. I think Angela and Karina, residents at Zucker where I work, have heard me say that with this population in my work at an ACT team before and at Project Renewal, that it's a dance, right? You have to do that dance of engagement, and it can be a years-long dance. I'm just curious how, right? How to be able to resource that appropriately, to be able to give the appropriate funds to that, and be able to show perhaps some outcomes to a government that wants to see everything fixed right away, is where I think it makes it very hard to sell that dance with such a complex population. But very well said. Any other thoughts from our panel about wish list for future direction?
I just wanted to say at Project Renewal, you mentioned post-COVID, and then I don't think any of us addressed it. So during COVID, hotels shut down, and Project Renewal, because we had to isolate people rather than 6-7 beds, we put them in hotel rooms. We thought people were going to have more overdoses because they were alone. So our substance use shelter, when it moved to a hotel, we were very worried about that. We were worried there'd be more incidents, more problems. It went beautifully. People had their own room. They had their own bathroom. They had privacy. They felt like it was more dignified than the shelter. Incidents plummeted. Calls for 911 and people needing to go into the emergency room plummeted. So if instead of building, and then the problem, of course, became the not in my backyard. And there was, you might remember some of the giant protests that happened at one of our sites because, and I think that's the other thing the mayor is trying to address, and not the way that I would prefer, which is let's take people and put them in a hospital, put them in an institution, put them somewhere else so they're locked up and out of people's sight, versus if we could, instead of buying and building new property for new supportive housing, if we could use hotel, rooms or that kind of thing, there's a way of doing that, but then you have to have the buy-in also from the community who are willing to have some of these kind of places around. And so when COVID ended, the hotels went back to operating as hotels and everyone went back to shelter.
Yeah, I had wondered how that hotel experiment had gone, because the media certainly did not love that. But I would imagine if I were street homeless or in one of the shelters, that I would have loved that. So yeah, that's a very interesting perspective. I'd like to open up to the folks who've joined us for any of your questions for our panel. I think I've kicked some of them off, but I know you all are sitting there with lots of questions. Dr. Greenspan has unmuted.
Oh, stop calling me Dr. Greenspan, Anna. Mike, everybody, and thank you, all the panelists. I guess I have a question, but it's particularly toward California. And before I do it, I just want to thank everybody. This has been fascinating to hear, I think, and very helpful. I also want to thank Doctors Liu and Lashley, two interns in our program over at Zucker, who started a public psychiatry interest group, which we had never had. And there's nothing fixative like now, but I think long game is optimistic because there's a lot more interest in this space than there has been over the decades. But Dr. Goldman, question for you, because I was curious about this. What was it called? Care Connect or the Care Court?
Care court, yeah.
The idea of kind of putting on a county an outpatient treatment mandate / liability. It's very interesting in like a very California way, I say, as a lifelong East Coaster. I assume not, but I'm curious, like what sort of implementation can that have in the community? Can the court, for instance, can the county go in and give medication over objection? I assume not, but could they?
No meds over objection. That's explicitly not permitted under a care court order. It's a little bit of a confusing thing because like the judge is telling the county you have to provide XYZ, mental health, substance use, housing type services. But the person themselves has to demonstrate that they're not willing to voluntarily participate in a care court proceeding. And so there is like some risk that if somebody really resists it and the county is unable to actually engage somebody in care, that's then sort of like an on-ramp to what we call conservatorship, which is equivalent to guardianship in New York. And so that's a concern, is like, wait a minute, is this actually just going to be an on-ramp to that much more sort of restrictive paternalistic type intervention, which some people are totally okay with. And I think others are concerned that that might not be a good outcome for a care court proceedings. I think that, care court is, I think it's going to serve best like the NAMI families, like people who are, parents with young folks in their lives who had a horrible, serious mental illness diagnosis, like in the prime of their lives. They see their kids out on the streets just not engaging in care and their hearts are breaking and they're saying, do something. And so the governor said, okay, here's a shot at it. I will say, one of the challenges that I think counties are facing is that, so counties are mandated to provide services regardless of payer. Usually for under care court, usually counties are providing Medicaid population, services. And so if we're now mandated to provide intensive case management for somebody who's got private insurance because they're 23 and still on their parents' plan, that's then taking a slot for ICM that otherwise would have been one of our Medicaid patients who would have been getting that. And so in terms of the resource allocation questions and the energy spent and populations prioritized, it does sort of reconfigure some of that, but like there it is somewhat zero sum given the resource constraints. And so like who benefits, but then who potentially gets sidelined, that's some of what we're really I think figuring out as we're planning for this. And no county has yet implemented care court. The first county is the cohort 1, we call them, is starting in October. So that's going to be closely watched as these programs actually roll out, is to see like who are the populations who are actually coming through and how are we actually serving them.
We appreciate that.
Would be nice to see some concrete data as that rolls out. Right. All right, cool. Dr. Geis, I see your hand up. Oh, you're muted.
Obviously, there's a housing issue. Obviously, there's a payment issue. And I know New York is obviously unique in many ways, but I'm wondering what people's thoughts are, and as a workforce issue, about introducing this issue into residency training, because I think nationally, certainly, most residents don't get experience with street medicine or with homeless services. And so I think looking forward, that's another issue that theoretically could be easier to address than the housing and the funding, which is very complicated. But I was wondering if anybody could speak to that, getting more exposure to trainees to this issue to increase the number of people who focus on that problem.
Well, I'm not on the panel, but I could speak a little bit to it.
I
Just 'cause
think
I'm a
Mike can
resident.
definitely speak to this, yes, as a residency program director.
Right, I am a residency program director, and there's two. I'm kind of with two co-experts, the folks who I identified before. I mean, locally, we're trying to build, and Angela and Karina are at the very front of that margin, building relationships in Long Island, potentially in New York, to try to get exposure, clinical exposures, which don't exist in our system. Northwell, which is a very large system with a lot of public psychiatry provision, but street outreach is not existent. There's social justice tracks and public psychiatry focused tracks within residencies that are popping up across the country. And that's, public psychiatry fellowship as a training others can speak to, because there's folks who have actually gone through it, but it's not been around for decades. These are relatively new areas of focus that grow quickly. So I think that's going to, but I missed Leslie. This is going to happen more. It's hard to predict the pace of it. This is actually a pretty privileged room, a lucky room in terms of experts and mentors. On our campus, we have Dr. Kostakis and like other people, but not every residency training program has those resources. So figuring out how to get that and provide it broadly is the challenge, I think. But if you want to tell it in from Hawaii, we'd love to have you give a lecture or two.
Homelessness is an enormous problem here, even though we have even better weather than California. Living in the street is hard, especially on the beach. And so it's different in 150,000 people on this little speck of sand in the middle of the Pacific, 6,000 miles away, where everybody knows everybody. It's a lot of different issues in a rural setting.
And I'm going to jump in, doctor, to say that I think it's more expensive to live there too. I think the cost of living is very high, if I'm right.
Well, that's what everybody blames everything on.
Well,
it's a
but
much
it
more
is
complicated issue. But it depends how you live and stuff like that. But there are issues with that. But homelessness is a huge problem here. It did go a little bit down this year from efforts to do some of the things you're talking about. Our new governor, Josh Green, is a nice Jewish boy from upstate New York, but he's an ER doctor on the Big Island, still working. And so he has prioritized some of this, but he's much more of a politician than he was in the 90s when I first knew him more as a progressive. So we'll see how much he's able to do in this regard. But I went to Columbia to medical school, and I know a lot of the people in the public psychiatry program because they were at Einstein when I was in training there in the 60s, but that's just one program. And so in our medical school here, where I'm a clinical professor, I think there's been a kind of disconnect between the one person who's been involved in this issue, and the residents really don't get any exposure to this.
Ellen, I think you were going to pipe in.
Yeah, I was just going to introduce another topic we haven't discussed about homelessness here in New York City, and it also applies to other cities as well, is people who are undocumented and homeless. and like the limited resources they're able to access is a big issue. Especially with the issue of like people getting bused to other cities, and like New York being one of them. And so it's been challenging in that sense, where like at least during one of my, like I also do outreach in Queens. And so there's Breaking Ground, one of like the homeless nonprofits, does have a pilot program in terms of like having people who are undocumented have a bit more access to like medical, psychiatric care, including medications. And in terms of housing, it's like, I feel really stuck in terms of how to be able to help them access those services. So it's not necessarily like, I don't necessarily have an answer to that right now, but I just wanted to bring that up as an additional issue when we're talking about homelessness.
It's a huge issue, absolutely. I mean, I distinctly remember the folks at you know, in Washington Heights at Fort Washington Men's Shelter, who were like the fixtures there, and everybody else would slowly get housing. And these guys, like a couple Polish guys that I spoke with, since I speak Polish, and you know, a few others who were undocumented, were like the fixtures there. Like it's like they had to permanently move into the shelter, and that's no life. I'm curious if any of then these initiatives from the mayor's office address that population at all, from what you've seen. No. So if they come into the hospital at all, Becky, you can't send them on to any of these resources.
Correct. So we can't, I mean, I could send them again to a state hospital. I can, and I can get them an IMT team, but it's all connected to Medicaid, Medicare. And so supportive housing, SSI, SSD, they are not eligible for any of those benefits.
So frustrating in places like, I think, right, San Francisco, New York City. I mean, these are hubs of undocumented folks, and a huge need. So Alan, thank you for bringing that up. Any other groups, any other topics related to this that we haven't touched that we really should? Not that we're able to solve all of it together, but at least we've explored it pretty fully.
Sorry.
Jillian, please go ahead.
Someone had said earlier about burnout and staff and quality versus quantity. And I can tell you from like my own clients' experiences, you know, ACT teams are great and IMT teams are great if they are staffed with great people. And I have a woman right now who an ACT team member came in this week to say, oh, no, just keep her there. Like, she's much better inpatient. Like, we can't take her back yet. I can't handle that. And, you know, the legal standard isn't whether you can handle someone, it's whether she meets the criteria to be hospitalized against her will. And so there's a lot of, just give her a long-acting injection. That way she'll be out of the hospital for at least 30 days and we don't have to worry. You know, I think it really, it's the quality of people and the people that are invested in this issue that are going to make the difference. And I completely believe in establishing relationships with patients, clients, whatever they are to you. But unless we make someone feel that they're safe and in an environment where they can talk to someone without the threat of 911 being called or being hospitalized, we are not going to improve anybody's life. So I think that's a really key thing, of that if we need services, it has to be services that are staffed adequately and with people that want to do this kind of work.
I had a question about if you took the initiative on face value as a method of treating mental illness, and how effective that would be. As you know, I've worked in emergency room, worked various settings, and say one's in the emergency room and collecting information about safety issues, and you pass it on to a colleague, Well, if you haven't communicated it well, sometimes they will ignore what you've done and say, person's not looking to kill themselves or someone else ignored, a lot of the data you've collected. That person gets discharged. If you're an outpatient doctor and you just say, okay, this guy needs an evaluation, or this woman or whoever needs an evaluation in an emergency room, and you just call 911 and you send them there, the chances of them getting admitted, I have found, are slim. Now, if you find out which hospital they're going to, you ask for an attending, it seems like there's more of a chance, because then you're saying, this is what I'm seeing. And the same must be for police. Police may be seeing certain symptoms. A person is screaming at people out on the street and appears manic and, has had people shoot at him or something, right? I've seen a case like that. But to say the police may bring them in for that reason, but they may not have the training to say, okay, this is what I'm seeing. And this, and please call me. Police will sometimes give a card and say, you call me, but they may not have that training. And if I, again, as an outpatient doctor, if I just call 911, which I do with some frequency, if I don't follow up and if I don't have it done myself, meaning I could assign it to my social worker, but if they don't use that language that is going to communicate to the emergency room doctor, this is why the person is not safe right now, that person doesn't get kept. So I wonder, in a very practical sense of picking people up of the street, if you don't have this line of communication and way of communicating the safety issues, whether it's at all meaningful, or if it's just a gesture. And often that it is just a gesture if you don't do it yourself. That's been my experience. That was an issue I didn't feel like was being addressed here.
It's a very good point. And I think the continuum of care is so siloed that it makes that communication very hard. And I think, even within Northwell, I know that I can communicate that effectively to the people I directly work with, but outside of that little bubble, that makes it very hard. And it's a very complicated system. Any thoughts on that issue from our panel?
I think that happens all the time, and that ineffective communication, the folks in police and EMS don't have as much mental health training, right? It is then more and more people coming to CPEP for an evaluation. As we've said very clearly, the legal statute hasn't changed. And so if you don't have the information in the emergency room that this person's actually in acute danger to self or others, they're not going to be admitted. But it is kind of an empty gesture, but it's an empty gesture, in my opinion, which is not without risk to the individual who has been picked up, brought in, and had their life interrupted for whatever period of time. And it's not an efficient use of our, as we've said repeatedly, very stretched resources to do an evaluation, maybe hold the person 24 hours, maybe not, maybe do some expensive blood work or eutoxes or whatever we're going to do in the emergency room to try and evaluate this person. If there's no other evidence that this person's in acute danger, self or others, that's still a significant investment in everyone's time, effort, but not the least of which the patient who had to go through this rigmarole.
Absolutely. Very well said. Not sure that we have any solutions, but I think identifying the problem at least helps us a little bit. Any last questions for our panel?
Well, I did want to take a comment in terms of continuity of care. So there is some sort of incentive for people to call after someone's discharged from the ER or the inpatient unit to be like, oh, did this person follow up with you, as a way of, and I'm sure that's tied to some financial incentive because it's done frequently, but there isn't any sort of incentive to call during the hospitalization before they get discharged. So from a systemic point of view, like figuring out what ways would help incentivize people to reach out sooner in the hopes of like providing better care for our people.
Yeah, and the other thing I would say is data integration is really hard in this space because there's so many different systems that just totally don't talk to each other. So if you're talking about information sharing, that can be done manually and incentivized, but it could also be done automatically through flags or things like that. You guys have psyches. We don't have anything like that here, but that is a mechanism where, like, if it flags an acute care episode, like that, I think is supposed to notify outpatient teams or things like that. So anyways, that's sort of another approach, is to facilitate that kind of information sharing.
Could I say one thing, Anna?
please.
I just want to say, I've been doing this for 50 years now, and I'm extremely interested, but I am inspired to see 36 people, young people just going into this field. That would not have happened 50 years ago. You couldn't have found 36 people in the United States who are interested in dealing with this problem. And what you've said is right on and quite helpful. There actually are solutions to a lot of these things. But the main thing is Jillian's comment about how if you have this in your heart and your mind too, that you're really interested in seeing this work, whether you come from a legal perspective or clinical perspective, you all are just marvelous. That's all I want to say. I don't want to go into all the details, but this was just an inspiring program. That's why I signed up for it. I think it's terrific that the district branch has done a program on it, and I just can't believe seeing you all there. And it makes me hopeful toward the end of my career to see what you're going to contribute, because it's going to change.
Thank you. And I swear I didn't plant Dr. Tucker. There is no better way to see us out from this conversation, I think, than that, with that ray of sunshine, because I think it's very easy to get bogged down with all of these issues. And I think I have found comfort to know that from every perspective, whether it's the legal, inpatient, outpatient, clinical perspective, from the other coast, from Hawaii, we're all struggling with the same issues, but I am heartened by the discussion and by the village that I think is working together to be able to find solutions moving forward. So with that, I wanted to end respecting your time for this evening, but very much wanted to thank all of our panelists, Lisa, Allen, Matt, Becky, Jillian. Thank you so much for all of your wisdom. Thank you to New York County Psychiatric Society, to NASA Suffolk District Branch, to Mike linking us to NASA Suffolk, and I bid you all a good night, and hopefully a continued conversation that has been sparked here to be able to make some change moving forward. Thanks.
Thank you all. Thank you all so much.
Thank you.
Thanks, and thanks, Anna, for organizing this.
Yeah,
Appreciate
thank
it.
you, Anna.
Great job.
Good to see you all.
And to all of you.
Bye, everybody.
Have a
Bye.
good night.
Yeah.